for everybody that's on, I'm Josh Rosenow. I'm a neurosurgeon at Northwestern. I've been at Northwestern this is now my 19th year. It's hard to believe. It doesn't feel that long, but it's my 19th year. And I'm the senior epilepsy surgeon at Northwestern and the director of what's called functional neurosurgery. So I have a background in both epilepsy surgery and what's called stereotactic surgery. So I kind of have dual training and stuff that in the old days of epilepsy surgery, the dual training really wasn't as relevant. But in the new era of epilepsy surgery, a lot of the techniques that we use for this specialty called stereotactic surgery, we now use very frequently in epilepsy. So it comes in very handy. And so I've been the senior epilepsy surgeon at Northwestern for now 19 years, and we've really had a great success with our program here. At the hospital, I do a lot of administrative stuff within the medical group in terms of running the functional surgery program across our health system. Our health system is 11 hospitals, and I have the administrative direction of that. I don't do epilepsy surgery at Central DuPage. I do some other surgery there occasionally, but I do oversee programs out there as well. I have a junior partner named Katie Bant who does some epilepsy clinics out at Central DuPage. In national neurosurgery, I do a lot of work with things like advocacy for neurological surgery procedures. We're the folks in neurosurgery who work on, say, appealing insurance company policies that may be detrimental. Like if your insurance company doesn't want you to have epilepsy surgery for some reason, or we want to expand the indications for something like VNS or RNS or DBS for epilepsy. I'm part of the groups in organized neurosurgery that are ones that work with the insurance companies to petition that. So for instance, I was the one who worked with Blue Cross Blue Shield of Illinois, Texas, Oklahoma, New Mexico, and Montana to get them to accept laser for epilepsy. So they had traditionally had a policy against laser for epilepsy, and we got them to overturn that. We also have new codes for laser that are coming out in January that we wrote, and we're working on similar things for the RNS system now as well, because these are all new technologies that the way that we code for surgeries don't describe yet. So I do a lot of things within epilepsy surgery around the country, and I'm just thrilled to talk to folks about what we do, and if you guys have questions or everything. Oh, I just saw something in the chat. It's stereotactic. So stereo, like your stereo at home, tactic. So it's STEREOTACTIC, stereotactic surgery. Yep, like that. Like what I just posted.
Can you elaborate a little bit more, Dr. Rosenow, on that stereotactic surgery?
Sure. So stereotactic surgery involves using a variety of techniques to very accurately place things deep in the brain. So the most common uses of stereotactic surgery are for certain kinds of things like brain biopsies, or really in our world, it's for things like deep brain stimulation. That's mostly what people think of. So whereas in the past, things like deep brain stimulation were mostly used for things like Parkinson's disease or tremor, we now obviously use deep brain stimulation for epilepsy. The RNS system is a version of deep brain stimulation in some ways. It's a very sophisticated version. So we place electrodes for RNS in very similar ways. The same thing when we do what you may have heard about, this technique called stereo EEG that we use for invasive EEG monitoring. Stereo for stereo EEG is the same origin of stereo, like stereotactic surgery. So back in the old days of epilepsy surgery, like say when I was in training in the 90s and early 2000s, these two worlds didn't collide very much. But now that we have all these ways of doing very sophisticated, minimally invasive surgery, things like RNS, DBS, laser, stereo EEG, all of these things use these techniques that we use in this other part of neurosurgery, now apply it to epilepsy surgery. So we can do more stuff, less invasive, and treat more people and get them out of the hospital and back to living faster.
So do they end up then eliminating the seizures, the DBS, or reduce, what results can people expect after a DBS or an RNS?
So obviously the results are going to be a little variable depending on every individual person's epilepsy, which is very unique to them. But the idea behind something like DBS for epilepsy is a system that will stimulate some target deep in the brain, and there are several targets that are used, and stimulates it constantly in an attempt to reduce seizures. And just like we see when people have VNS implanted, it's an effect that is progressive, meaning it's not like it's a light switch, right? You don't turn the DBS on and the seizures go away, but you see them kind of come down slowly. So just like we tell people with VNS, people with DBS are often better at 6 months than they were before the DBS. And then hopefully they're going to be better at 1 year and 2 years than they were before the DBS, but it's a progressive effect over time. But it's not something that we typically think of as a cure. It's something that can provide significant reduction in seizures, and people can even go in certain circumstances with prolonged stretches of seizure freedom, but it's not something that we think of as giving someone permanent seizure freedom at times. Now, RNS is a slightly more sophisticated version of that, right? So RNS is a device where the battery just doesn't pump out electricity. It actually listens to EEG. So DBS is a general treatment. You stick it in a place in the brain that's meant to kind of treat DBS as a network disorder, meaning somewhere in this path of someone's epilepsy, you're putting the DBS in the middle of that path. But it's not like you're putting it in the spot where the epilepsy is.
So then is DBS better for generalized epilepsy?
So we're still trying to figure that out.
Okay.
There's still a lot of people trying to use DBS for various kinds of epilepsy and see how it works. The initial target that people were using for DBS for epilepsy was an area in the thalamus, which is an area of multiple nuclei deep in the brain. Thalamus is kind of like the grand central station of the brain. Just about everything relays through it. And I'm a New Yorker, so I use Grand Central Station. Everything kind of relays through it, and it has multiple different train tracks. So there's sensation area, and there's thinking areas and movement areas. So there's one area called the anterior nucleus of the thalamus, which is a small area that actually is a relay center for some of the circuits that actually involve the temporal lobe. And so that's the initial target, and that's actually the FDA approved target for DBS for epilepsy. But there are some other areas in the thalamus that we've been using for other sort of neurologic disorders for DBS for a long time. And there's a lot of work looking at some of those areas for DBS as well, and RNS, believe it or not. So RNS is a more sophisticated version of DBS. So DBS is not smart. DBS just pumps out electricity. We tell it how much, how strong, and it just goes 24/7, bzzz, like that. RNS, on the other hand, is smart. So it listens. Okay, it listens to EEG, and then we teach the RNS each individual person's abnormal EEG, and it stimulates in response to the abnormal EEG patterns that we teach it. And then we can control how strong that stimulation is, how long it lasts, how fast the pulses are, and how long each pulse is. But unlike DBS, RNS is placed in the spot of the epilepsy. So for instance, if you have an area deep in the brain that we know is a seizure focus that we can't remove, you can put an RNS electrode there. If we have epilepsy in a very sensitive functional area of the brain, say your speech area or your main movement area for your hand that we don't want to remove, you can use RNS in those areas. Say someone's dominant hippocampus, very common, that you don't want to remove because it could cause memory deficits. Or if someone has epilepsy from both hippocampi, then you can't remove both hippocampi. And so RNS is something that requires you to understand where the patient's epilepsy is coming from rather precisely for the treatment to have the best effect. And like DBS and VNS, the RNS effect is also progressive, both because the effect happens over time, like DBS does, and also because it takes us time to really get the programming up and figure out what the best seizure zapping sequence is. But it's one of the interesting things about RNS is that over time, you can see in some people, the number of stimulations from the device actually go down. So in the beginning, you see the number of stimulations going up like this. Every time it senses something, it's stimulating, but over time, that curve flattens in some people, meaning the EEG actually gets less bad, as they say. And there are fewer instances where it has to stimulate. So we're still learning this what we call this neuromodulation effect of RNS, but it's a very interesting observation. And Again, it's a very different device in some ways than DBS, even though they're both stimulating the brain. But it's certainly a rather novel way to look at treating those sorts of epilepsies.
Yeah, you were saying it was kind of interesting. Thank you very much for surgically curing my epilepsy. And when I went into, yes, and when I went into the surgery in 2012, I went in to stop the seizures, right? I had no idea that maybe someday I could go off medicine. And so, they ended up going into my hippocampus and removing it. And I haven't had a seizure since the day of my surgery. Oh my gosh, it's still a miracle. I can't believe it. And then after being seizure free over a period of time, Dr. Shule lowered my medicines until I went off them completely. And then after being off them completely for a while, he diagnosed me as living proof of being cured. So, but the interesting thing is I really never needed to go off medicine. My life changed completely the day after surgery. My memory started to get better. I started to read a lot more to try to rehabilitate it and exercise. So I improved tremendously on medicine. So it's okay to be on medicine and to have the surgery because my life was remarkable starting after surgery as I began to heal over a period of time. So thank you very much.
No, that's tremendous. I mean, that's why we do what we do.
With talking with people, if you don't mind, some don't understand what an EMU is and how you figure out the spot and take out the guesswork. Is there a way to explain an epilepsy monitoring unit where you decide to put the DBS and the RNS and laser and
sometimes all in one person? No, sorry, not all in one person. Right. So I can talk a little more about the general way that we figure out who should get epilepsy surgery. So it's actually a pretty extensive process in that we go through a series of tests, and our folks who go through the process is, as you know, Becky, and as some other people who may be on this call probably know, it's a lot to go through, and that's one of the reasons why we have such pride in our epilepsy patients, because you're all just so dedicated to things, and people with epilepsy just really want to get rid of it so much that we'll do as much as we can to help them out. And everything that people go through to get to surgery, we just makes us want to work harder and harder for them. So it starts with, just having a good outpatient evaluation and making sure that people understand what an outpatient EEG looks like. So the first thing starts with an outpatient EEG, and sometimes an MRI, a good epilepsy protocol MRI, and there are very specific protocols for epilepsy patients. And so if people with epilepsy are getting an MRI, they should make sure that they're getting an MRI that's specifically done to look at in ways to look at seizures. If people ask, what's the biggest advance in epilepsy treatment in the last 30 years? The answer is MRI. That we have high field, meaning 3 Tesla and above MRI, and certain what are called MRI sequences, meaning how we make those pictures in the 3 Tesla magnet, that can show us MRI abnormalities, very subtle MRI abnormalities that we could never pick up before. So people who were told previously that their MRI was normal might not actually have a normal MRI. And that can guide us a lot when we think about surgery. Once we get to the point where we think it's worth having someone come in for a more in-depth evaluation, that's when patients come into the epilepsy monitoring unit. In an epilepsy monitoring unit, every room has a high channel EEG box, so it can actually take many more channels of EEG than just a regular scalp EEG sometimes, and a camera looking right at the person. And so what we aim to do during an epilepsy monitoring visit is have the person on 24/7 EEG and video at the same time. That way we can correlate in real time clinical features, meaning how someone looks and what they feel when they're having a seizure, and what their EEG looks like, for a couple of reasons. One, there are a lot of times that people don't know they're having a seizure, or people have seizures at night and they sleep right through them. So sometimes people would say, well, I haven't had a seizure for 3 months, And then we bring them into the epilepsy unit, even on all their meds. And we go, well, you had 4 seizures last night. And they go, no, I didn't. We go, look, here's your EEG: seizure at 1 a.m., seizure at 3 a.m., seizure at 4 a.m. So these things happen. Or even in the middle of the day, we have plenty of times where people are just not aware they're having a seizure. They're watching TV, they're having a seizure. Someone comes in, asks them what they want for dinner. They walk out, they're having a seizure. So the epilepsy monitoring unit both lets us get a good idea of what the clinical features and the EEG look like together, as well as sometimes get a better idea of seizure frequency on meds often. Yeah.
Sorry. So now I did speak with someone who is going to be coming into the EMU, and she's scared to death. She's scared that she's, going to have she's scared. Is there any way to relieve that stress on her so that she that she knows she's in excellent care, that she's going to come out of this okay when she goes to the EMU?
So, people who have epilepsy spend most of their time thinking about not having seizures. And then when we have someone come into the epilepsy monitoring unit, it's everybody staring at you saying, now have a seizure. Like, it's the one thing you never want to do. But epilepsy monitoring unit is set up with specific safety protocols, specifically for people who have seizures. And so the staff there is all trained in seizure safety. There's somebody watching these cameras 24/7. There's someone there in the EMU 24/7 with people. Everything is set up for seizure safety. People are monitored with EEG, EKG, meaning heart rate stuff, breathing monitors. Our patients are like wired for HD, Netflix. You can't imagine how many sensors are on people. And it's all set up with nursing protocols and other things for safety. We understand that it's a tricky situation when patients have seizures, and we don't want anyone to get hurt or have a problem when they have a seizure. So it's probably the most controlled environment you can be in to have a seizure.
Thank you.
So let me just going back to what I was saying. So after we finish a video EEG evaluation, we sometimes will add other imaging studies on top of the MRI. We can add what's called a PET scan. So PET stands for positron emission tomography. This is a scan that looks like how the brain uses fuel. So we take people and we give them intravenously, we give them basically radioactive glucose, because glucose is the main fuel for the brain. And then you sit in what looks like a CAT scan. It's a big camera that looks for the radioactivity that comes out of this radioactive glucose, and places in the brain that are using fuel normally, the normal areas of the brain, show up with more tracer, and the areas of the brain that may have seizures often are not using glucose normally, and they'll show up as using less fuel. We also sometimes do a scan called a SPECT scan. A SPECT scan is single photon emission CT. So photon is another kind of radiation, but this is a blood flow scan. So if you think about it, when an area of your brain is seizing, it's using a lot of energy, right? It's seizing, it's seizing, it's seizing, it's seizing. And those areas in the brain that use a lot of energy also happen to get more blood flow during that time. So what we look at is the distribution of blood flow in the brain. So when people have a SPECT scan, we do 2 scans. We do one when they're not having a seizure. So we just give them this intravenous tracer, and then they go get scanned, and we see what their baseline blood flow is. And then we do what's called an ictal SPECT. Ictal means an event. So we do it when someone's having a seizure. So basically it's like during an EMU visit, our techs are sitting around with them, sitting right next to them with a little syringe of this radioactive tracer. And as soon as someone says, oh, I think I'm having a seizure, well, we see it on the EEG, boom, in goes the tracer. So it circulates, the seizure happens, it ends, and then we put the patient right in the scanner. So now we have one scan with resting blood flow when there's no seizure, and a scan with the seizure. And we put them together and do what's called subtraction. We take one away from the other. So if you think about it this way, if a normal area of the brain has blood flow of 10, and that same area of brain when having a seizure also has a blood flow of 10, 10 minus 10 is 0. So it drops away. If the normal area has a blood flow of 10 that's causing seizures, and then when you're having a seizure, it goes up to 15, 15 minus 10 is 5. So that area shows up as brighter on the subtraction. So what you see on the subtraction picture is all the areas that are not different between no seizure and seizure go away. And then you see this bright spot where you have increased blood flow only during the seizure. And that's and that helps guide us to where a seizure is. So as I said, so now we have EEG out of the hospital, video EEG in the hospital. We can get a PET scan, which is brain metabolism, SPECT scan, which is blood flow during and not during a seizure. We also get cognitive evaluation, so we can look at how the brain is functioning cognitively, because certain areas of the brain, if they're not functioning well because of longstanding epilepsy, from things like thinking and memory, can help guide us to areas that have chronic issues because they're producing seizures. And we get those kind of studies as well. And then we all sit down as a team. So we have minimum of 3 meetings a month as a big team, physicians, nurses, across the spectrum. And we sit down and we go through all of this data together as a group. We go through everybody's history, their clinical features of their seizures. We watch their videos. We look at their EEGs. We look at their MRIs and all these pictures. And then we talk about what we think is going on. We try to get a consensus on where we think their seizures are coming from. And then we try to come up with a plan as a group so that we can then sit down as a group with the patient and their family and talk about what we think is going on and what we think the options are and what the good and bad things about those options are. And that's the basics of a general surgical workup. Again, it's pretty extensive, but it's important that it's that extensive because, right, we want to be in the right space. We want to make informed decisions about what we do, because when we do things right, great things happen.
Yes.
Great things happen.
Right.
What's the time frame? So of this entire workup, is it like 4 months, 5 months, 6 months?
So it can be pretty variable, meaning sometimes we can do things pretty quickly, but pretty quickly for this can take 2 months. Or sometimes it can be extended, both due to our calendar, like sometimes, you know, our EMU gets full and backed up and it could take us longer to get someone in. Obviously during the pandemic, our EMU was shut for a little while. So that backed us up for a bit once we reopened. We also might have a little crunch coming up because our EMU is doing so well that we're actually going to be expanding it and building out a bunch more beds. And so we might have to close some of our existing beds while we build out more beds. And then depending on what happens with other things, some of those things, like if we need to do surgery, then there are surgical calendar things that may rely on team dates. And, you know, because this isn't emergent, you know, we try to schedule around people's lives. Some people have preferences, you know, I want to do it on a school break, or I want to wait till next summer, or I want to do it in March and stuff. So it can be very variable in terms of how long this takes. But I would say in general, from the first time we bring someone into the epilepsy unit till the time we sit down and talk with them about plans is usually about 6 to 8 weeks. But then if there's going to be surgery, it may be another 3 months till we get someone in an OR, depending on things.
Okay.
I have a question. My son is 25 years old. His first seizure was at 7 months old. And he was in the EMU for a week in August. And he is aging out on our first visit with Dr. Demo. We'd been treating at the Cleveland Clinic. First, we treated at Children's with Dr. Cindy Stack. And then she referred us out to Elaine Wiley at Cleveland Clinic. We've been treating there until early this year. Elaine Wiley is a pediatric epileptologist. So we wanted to get back into the adult epileptologist genre. We met with Dr. Demo for a virtual visit April 1st. And Anthony, my son, ages out on my insurance at December 31st of this year. Then he'd have to go, you know, on his own. And so he was supposed to be the subject of the management conference on September 15th, but his time was run out before his case could be heard. So now his will be in October. Is there any hope at all that this would be accomplished? He would need the deep brain EEG monitoring with the probes, and then to come back in for right frontal lobe excision. It's non-lesion epilepsy. So is that a time frame that is even in any way realistic? Because none of that has been talked with us, and even loved ones and family members have said, well, you know, what's the time frame in getting this done? And we just scratch our heads and say, well, we don't know. So I'm glad somebody brought up this question. If is there any chance that a patient that's a subject that is presented at the October management conference for neurosurgery would be able to have their surgery before the end of the year?
Well, let me start by saying I'm sorry for the delay from September to October.
Oh.
I know that must be frustrating. Unfortunately, you know, that sometimes happens because, you know, people like your son are complicated. And so sometimes the time runs out depending on the complexity of the other patients. But I would say that even if we had talked about him in September, the chances that he would have those two operations within this calendar year, it's not going to happen.
Okay.
Even with that timeline. So the slip from September to October is not an issue in terms of that timeline. You know, the end of the year used to be, you know, there's always an end of the year rush in healthcare because, you know, everybody's deductibles resetting in January. And so everybody wants to get into the hospital in the OR before the deductible resets. In the old days, you know, it used to be that would start after Halloween, that starting the beginning of November, everybody would come in, oh my gosh, you know, I have 2 months left and, you know, I want to get this done before my deductible runs out. Resets, I mean, but now, you know, open enrollment for a lot of people's insurance policies at work starts in early to mid-October. And, you know, nobody knows what their insurance is going to look like next year anymore, right? I mean, who knows these days what anyone's insurance is going to look like. So now the end of the year rush starts in July and August. So we start to have people running in August saying, oh my gosh, I need to get in the OR before the year ends. So our end of the year has been pretty full since about September already, like since earlier in the week. We were just going over our surgical schedule today for some things, trying to do a little Jenga with how things look to try to fit in things that absolutely have to go and what may need to get moved around and where to make time on days that don't exist. The end of the year is always a difficult time for us, and we're always apologizing to folks for that.
Thank you. This isn't ever covered by Medicaid, is it? He's got a job that he will get, he'll be eligible for Anthem Blue Cross policy. So I told him, you know, boy, kiddo, do whatever you need to do to protect that job, because I have a strong suspicion that if you don't have your own private health insurance, that Medicaid would tell you, go fly a kite, you can have epilepsy for the rest of your life. You know, we quite frankly don't give a damn. You know, we'll give you medicine, but we're not going to ante up the money for surgery. Are you aware if that's something that, you know,
luckily that's not true. Actually, Medicaid does let you have epilepsy surgery. You know, it used to be that Medicaid was one thing, right? Like you had Medicaid, just like Medicare used to be one thing. You had Medicare, but one of the things that's gone on in the last 10 years is that Medicaid has split up into what are called Medicaid managed care policies. And so almost no one is on plain old vanilla Medicaid anymore.
Oh, good.
They now, well, good and bad. So because now people who are on Medicaid choose a Medicaid managed care policy, you know, instead of just saying I'm on Medicaid. The good thing about that is that they're on Medicaid, and Medicaid does cover epilepsy treatment in some ways. Sometimes some of the brand name or newer drugs might be an issue with Medicaid, but for the most part, surgery is covered. The issue is that the Medicaid managed care policies have made where those policies can be used a little bit more of a mess. So when it was just Medicaid, people would say, do you take Medicaid? And we would say, yes, we're a big medical center. Of course, we take Medicaid. But now, since Medicaid has been splintered into all these policies, that is much less certain who takes which policy. So, you know, we may take this Medicaid policy, but not that one. But then 8 months from now, we may take this policy again, but we now may not take that one. So there are certainly times where I have, you know, given what I do for a living, I implant a lot of devices into people that need, you know, long-term maintenance, either battery changes or things like that. It's not unusual for us to have emails to my colleagues around the city who do these as well, saying, hey, we have a patient who needs a battery change for a VNS. Do you take their Medicaid policy? They changed Medicaid policies like 10 months ago, and now we don't take their Medicaid policy. Do you take their Medicaid policy to change their battery? So it's made it a little more of a mess. But this is the way that Illinois has, and most other states also have chosen to go with Medicaid. We see the same thing on the Medicare side. It used to be that people used to just have Medicare, but now there are all these what are called Medicare Advantage plans that make things equally, difficult. Like people will say, well, I have Anthem Medicare. We'll say, well, which Anthem Medicare do you have? And they'll say, well, I have Anthem Medicare Blue, Green, Gold Choice Plus. And I'll say, okay, we take Anthem Medicare Blue, Anthem Medicare Green, Anthem Medicare Gold, Anthem Medicare Plus, Anthem Medicare Blue Plus, Blue Green, Blue Gold, but we don't take Blue, Green, Gold Choice Plus. I mean, there are just all these, right? It's just become very difficult. And look, it's not easy for us to figure out what covers what anymore. It's made it very difficult for us. And if it's difficult for us, and we have all these people here that are dedicated to doing this, it is really complicated for folks on your end to do this. I tried to, as a thought experiment, I tried to get on the Illinois Health Exchange and try to sign up for a healthcare policy to see what the experience was like. And I found it very difficult. Like I tried to say things like, well, if I had epilepsy, how do I know which one of these policies, I can go see my epileptologist under? And I couldn't figure it out. And if I can't figure it out, like, I don't know how a lot of other people are going to figure out. It's a big problem. Like, it's great that there's more access to health insurance. I absolutely love that, but there's got to be ways to make it easier. I can go online and get 15 home loans online in 5 seconds, and yet shopping for a health insurance plan is a maze of just confusingness.
Thank you.
Hello, can you hear me?
Yeah.
Thanks a lot for your nice talking. And this is Shiva. I have 2 questions, and I was wondering if you could help me. The first thing, I know that in the partial epilepsy, the seizure occurs in the special parts of the brain. And I was wondering to know, does the seizure onset change during the time for each patient or not? And the second question is that, in general, is there any common feature for all epileptic patients that help us to predict or detect the seizure?
So those are great questions. I'll start out with the second one first. Unfortunately, epilepsy is so variable from person to person that although there are certain common types of epilepsy that may be similar from person to person, overall, there's no one single feature that everybody who has seizures shares.
Oh, great. Thanks.
Now, the first question is, can the seizure focus change over time? And that answer is somewhat yes. Meaning that one of the things that we think about is whether long-standing seizures can actually kind of start fires in other parts of the brain. Mm-hmm. So if you have seizures over and over and over again from over here, can it irritate this place so that 20 years of seizures can now produce seizures from 2 places? So whereas if you'd taken care of this place 15 years ago, you wouldn't have this issue, but now after 20 years, you have multiple areas, and that's something called kindling. And that is something that we do believe happens, and it is something that sometimes worries us. The other thing that happens is some people can have actually multiple seizure foci, but that we only may see one really dominant one. And what sometimes happens is we might do all this workup and see one dominant focus for seizures, and we take care of that surgically, and we all pat ourselves on the back and we did a great job. And then, 18, 19 months later, seizures start back up again. And when we do some of these tests again, video EEG and things, we find that actually there's a spot that kind of woke up over here. Now, whether that spot was part of the epilepsy before, which it probably was, but it was just a very minor part. And so what we saw was this big area over here. But yeah, so you can have, when people have recurrent seizures, say after surgery, you can have other areas that are involved in seizures. And that's often when we might come back and do something like a VNS or an RNS or a DBS or something of that nature at that point.
Okay, thank you so much.
I had a question for you. So is craniotomy something that is not even part of the conversation? Are there so many advances in epilepsy brain surgery that it's just
Oh, that's also really good. Look, this is a tremendous time for the field of epilepsy treatment in so many ways. You know, it's been so gratifying after years of, you know, like when I was in training, like things really hadn't changed much in a long time. And then the last, you know, 10 to 15 years have really seen this explosion of new techniques and therapies, especially on the surgical side. But no, craniotomy is absolutely not out of the question. We did a craniotomy, today's Tuesday, we did a craniotomy yesterday for epilepsy. We have another craniotomy coming up. So we have a couple more coming up. So it's definitely not out of the question. But what I'll say is that certain of these newer techniques in a lot of ways are supplanting craniotomy. So for instance, when we think about, say, laser for epilepsy, when people have, say, right temporal lobe epilepsy, and the answer is you could have a craniotomy and have your right temporal lobe taken out, or you could have a laser and have us, you know, laser your hippocampus. It's very uncommon now for patients to immediately choose a craniotomy. When we first started doing laser, we still had patients that would be like, oh, I don't know, that laser thing is new, I'll still have a craniotomy. But it's very uncommon now. And so when we go talk to insurance companies who don't believe in covering laser, we say things like, look, you may not like to cover this, but like, and you may say you want like randomized studies of craniotomy versus laser, but that horse is way out of the barn. Like, you're never going to get patients to agree to be in this study, to say you have temporal lobe epilepsy and we're going to randomly pick a thing out of the hat and decide whether you get open craniotomy or laser. They're going to be like, screw it, I'm not in the study, I just want laser. So I mean, both the results, like the clinical results, and as we've gotten better with the technique over time, we've definitely do better now than we did when we started doing laser years ago, because we figured out how to do laser better. And as patients have learned more about it, and as they have developed preferences, as they should, it's their life, it's their surgery, right? We've definitely seen certain things gravitate. So we definitely do fewer full temporal lobectomies than we used to, okay, because we're doing more lasers. But you know, at places like ours and other sophisticated epilepsy centers, we still see enough patients with complex epilepsy that craniotomy is absolutely in there. Or we still see people that have what's called lesional epilepsy, which is you know, epilepsy with an abnormal MRI in places that we can go in and handle that just aren't handleable for, you know, with laser. So an area that's bigger than laser, like people that have what are called cavernous malformations that cause epilepsy, or what's called an encephalocele that causes epilepsy. Those are areas that we go in and handle with open craniotomy still. So while certain things like right temporal lobectomies are definitely, you know, less common now, craniotomy is not going away. And especially as we get better with all of these diagnostic techniques like stereo EEG, we still have patients that require craniotomy. Not to mention that RNS actually requires us to cut a little piece of the skull out, or sometimes make a little opening to put an RNS lead in. So
is RNS still indicated for 18 and older, or is it now approved for younger than 18?
I don't know the FDA approval for that, but RNS has definitely been used at centers in the under 18 population.
Okay, cool.
Even if it's what's called an off-label usage.
Oh, okay, great. Really good.
So when we've talked, Aisha asked about the craniotomy. What about a hemispherectomy? Do you hear of that very frequently? Or?
Absolutely. Again, it's I'm an adult epilepsy surgeon primarily,
Right.
so it's not a common adult epilepsy operation. But again, there are very specific epilepsies for things like hemispherectomy, or what we call hemispherotomy, because we don't actually take the half of the brain out. It's mainly a disconnection operation. And not only is hemispherectomy still out there, but my partner, Sandy Lamb, who's our head of pediatric neurosurgery at Lurie, is an expert in doing this endoscopically, meaning making a small opening and using endoscopes and stuff to do hemispherectomies at this point. So where not only is it still indicated, but folks like Sandy are doing this. It's more sophisticated, less invasive. So we're still getting better at it, meaning we haven't even stopped improving on these old techniques. So it's definitely still in the picture. For very specific epilepsies, there's no replacing hemispherectomy for those folks. And for the right people, it can be curative.
Right. Thanks.
I had a question about brain mapping. I worked with a couple of people where they had a brain mapping and like a right temporal lumbectomy. So can you explain what that is a little bit?
Yeah, it's not like Google Maps. So brain mapping is just, it's a very generic term, but it's based how I would take brain mapping is looking at brain function rather than listening to the EEG in the brain. I would think about brain mapping, and I think that could be what you're talking about, Becky, is looking at brain function. Okay. And so when we do any kind of invasive EEG monitoring, whether it be stereo EEG, which is just putting depth electrodes through the scalp and the skull like this without a big opening, or when we do an open craniotomy to put on grids and depth electrodes, we can both listen to the brain and we can stimulate the brain. And so stimulating the brain allows us to see what those areas do. So if we want to find an area that does speech or movement or sensation, we can do stimulation through these electrodes and see what those areas do. So for all of our folks who come in and have any type of invasive monitoring, once they're done having their seizures and we put them back on their medications, they all get at least almost a full day for some people of brain mapping, meaning we sit and go through each of these EEG electrodes in their head contact by contact, which can be tiring for some folks if they have 100 to 125 contacts in their head. We're checking this one out, then this one, then this one. So in the end, we generate a map of what all these areas do. Do they do something really important? Do they cause a seizure? Do they cause an aura? Do they cause some other sensation or other phenomenon that people have? Like, does it make them feel cold or hot or tingly, or do they hear things or see something? And we get a big map. So when we sit down to discuss possible options, those maps that we get in the epilepsy monitoring unit help us counsel patients and say, look, we think that we want to work on this area of the brain through whatever reason. And if we're going to either take it out or use laser on it, then this is what we think those side effects will or won't be based on the brain map. Or if we say, look, we think that this is a good area for RNS, it's because we found this function in that area. And we don't want to harm that function by doing one of these other procedures. So we'll go with an RNS or a VNS or something like that.
Okay.
Yeah, our folks who are in the epilepsy unit, meaning our epilepsy folks who come into the epilepsy monitoring unit, they're just tremendous people in general, as some of you on this might know. I mean, not only to come in and do all this and have seizures when the last thing you ever want to do is have a seizure, but then you sit through, everyone like sits through all this brain mapping with us, and I sit there and think about what they think, what they feel, what they don't feel. And then we also have this great opportunity to do research when patients are in the epilepsy monitoring unit. So if you think about it, this is a rare opportunity when we have people with EEG electrodes on and in their brain to look at the function of the human brain, in someone who's awake and hanging out. We do some research in people, when they're in the operating room, but that's a completely different situation when someone's just sitting up in bed hanging out. And we're lucky here at Northwestern, both having wonderful folks with epilepsy who agree to participate in these projects. And we have some really, really smart, innovative scientists who we work with. And we've been able, with the participation and partnership of our epilepsy patients, to make some tremendous discoveries, both about epilepsy and about other ways in which the brain works. Like we were one of the first places in the world to look at how neuronal impulses from smell go through the brain. And we've been able to find out things like, how people say in through the mouth, out through the nose, or in through the nose, out through the mouth. We've been able to find that those are actually different in how the brain works. Like in through the mouth and in through the nose, completely different in how the impulses go through the brain. We've been able to find areas in the brain that if you stimulate them, it makes people forget to breathe. Like they just sit there going, are you breathing? Yeah, whatever. And they're just not breathing. And then we stop stimulating, they start breathing again. But that gives us a lot of insight into what's called sudden unexpected death in epilepsy, or SUDEP, right? So we're trying to uncover these mechanisms, how these things work. We do things looking at decision making in various areas of the brain. We look at memory. We have all sorts of different studies that we do with folks for a day or so after they finished having their seizures. And again, without the generosity and participation of our folks who come into the epilepsy unit, we couldn't make all these awesome discoveries. So we always applaud our patients and just are so indebted to them for taking the time to do this with us. Some of them think it's really kick because a lot of times these are like video games that they're sitting there playing with all the EG electrodes in their head.
Dr. Rosenow, oops, sorry. I have found with some clients that I've worked with, I know my own memory improved quite a bit after epilepsy. When the seizures stopped, I could start reading and then remember it because it just wasn't getting zapped anymore. So is that normal for most people who have tried to get their seizures stopped, whether it's through RNS, BNS, through a surgery, that when their seizures, are reduced or eliminated, hopefully, that's what the surgery will do, is eliminate them. Are they also having memory improvements with rehabilitation, or did I just get really lucky?
No, I think that's a very interesting benefit to bring up, Becky. So as you pointed out, when your brain's having seizures, it's not working right. It's not thinking correctly. And so when we get rid of seizures with anything, surgery, medication, the brain is going to work better because it's not having seizures, which not only progressively damage brain function, but also, as you said, kind of wipe out whatever just happened. The other thing is, so there are two benefits to stopping seizures in that way. One is just stopping the seizures is better for the brain because it's not getting progressively damaged and wiping things out. And then two, if we're able to back off on some of the meds, the medications themselves can be cognitively dulling. I mean, people don't call Topamax dopamax for nothing, right? Remember, seizure medications work by slowing down abnormal nerve signals called seizures. Well, they don't just work on abnormal nerve signals, they can work on normal nerve signals too. They're not just selective for seizures in some cases. So that's why sometimes people can feel slower or sleepier when they're on certain doses of medications. And part of the sophistication of epileptologists is figuring out how to get the best seizure result from medications and the fewest medication-related side effects. That's part of their wizardry. But certainly, if you can just get rid of them after having epilepsy surgery, that's obviously the best outcome of all. But we have plenty of folks who feel sharper even after epilepsy surgery, even before their meds get reduced.
Oh, most definitely, because I was on a lot of medicine. And so my medicine was reduced a little bit, but it truly did not reduce until at least 2 years after surgery. And no, I found that it was stopping the seizures that my memory got better. I'm sure, reducing the medicine, yes, my cognitive skills got better as I kept reducing medicine. That's when I noticed that too. But yeah, I was amazed that I didn't realize how those seizures truly messed with my memory until they were gone.
Yeah, absolutely. I think that's a very common sentiment when people start reducing their medications, is that they didn't realize how much they felt like they were underwater until they got rid of some of the meds. And look, the medications are great when they work, but certainly if we can do something either with destructive surgery, laser, taking something out, or with something like RNS or VNS to help reduce seizures and use fewer medications, we'd much rather substitute electricity for medications or just substitute seizure freedom for medications.
Any other questions?
Can I ask a question? I know that for some epileptic patients, the brainstem isn't normal. I was wondering to know, is it related to some special types of epilepsy, or is due to the SUDE?
Sorry, that's what's not normal, the brain stem.
Yes.
So if the brain stem is not normal, that would probably be something related to developmental abnormalities, meaning something that happened during development, like one of the most common developmental abnormalities that we see, at least in the upper part of the brain, not the brain stem, that can lead to seizures, is what's called cortical dysplasia. So sometimes cortical dysplasia, cortical dysplasia is a disorganization of the nerve cells in the brain. So when the brain's formed, it's formed in a very orderly way from the inside out, where the brain kind of adds layers progressively. So the nerve cells are born kind of in the middle of the brain and then follow these highways out to the various layers. And if they don't follow those highways in a very orderly fashion, they can be disorganized in the cortex, and that can lead to seizures. Sometimes the cortical dysplasia is dense enough that we can actually see it on MRI, especially on some of those high field MRIs for epilepsy, like I was talking about earlier. But sometimes it's there, but it's just not clumped enough for us to see it. But when we send something to the pathologist, we can see cortical dysplasia there. And that's often the most common thing that we see in terms of, congenital abnormalities that results in seizures, especially in patients whose MRI appears normal.
Ah, okay, thank you.
So if someone wanted to have a consultation with you, Dr. Rosenow, what are the steps to get in touch with you?
So the main pipeline for epilepsy surgery is actually through the epilepsy center. So we have an epilepsy center number to call, because most people who get to me after we've done a big workup, rather than starting with the surgeon. You never want to start with the surgeon. You want to kind of end with the surgeon. So what we typically do is people call for an epilepsy appointment, and then if you have an outside workup, we can look at it before you come in. And so sometimes we won't even see you in the office. Sometimes we'll just have you go straight to an epilepsy monitoring unit visit to kind of start the process, and jumpstart it. So if you have any outside records like MRI reports, EEG discs, things like that, doctor's notes, we're happy to look at those ahead of time and see what the most appropriate first step is, whether it's a outpatient visit, whether it's a direct start in the epilepsy monitoring unit for video EEG.
How do you know, or when do you know it's time to go to an epilepsy center, and do you need a referral?
You never need a referral to go to an epilepsy center, but essentially what we know is that if you have seizures, you should probably be seen in a specialized epilepsy center, especially if they're not controlled with 1 or 2 medications at good doses.
Okay.
We just have, any of the specialized epilepsy centers has resources that we can bring to bear, either ours or at another place, that just aren't available in less specialized places.
I wanted to mention something as it relates to that, because my son has intractable epilepsy, and about 3 years ago, he had a bad seizure here. We started treating with a local neurologist who had a medication change, and that's always been very challenging to ramp up one medicine while you're taking another one down, and the side effect profiles of those medicines can make life very challenging. And I think my son has faced this condition with great courage over his whole life. But we met with this doctor in January just for a regular follow-up, and he said, oh, these 2 meds are working. One med was giving my son quite a bit of challenges with blurred vision and dizziness. And he said, well, we're keeping you seizure free on this. So far, so good. If you were to have another seizure, we'll just add a 3rd medicine. And so, and my son over 25 years has been on many different medicines. And then in March, he had a bad seizure. And so this doctor's approach was going to be to add a 3rd medicine. And so I started looking at this to see, okay, historically and prognostically, what's his likelihood of that this is going to work? And he only had a 6% chance that if a patient who has intractable epilepsy is not be able to brought under control with two medicines, there's only a 6% chance that any third medicine is going to make them seizure free. So I went to my son and said, you know, I think we need to get into the epileptologist, world again, versus someone that treats MS and, myasthenia gravis and other. I want somebody who, or I asked my son, we had Elaine Wiley, somebody was devoted entirely to epilepsy. And I think it's really important for patients that don't get seizure control with medicine to come to a monitoring unit in a specialized place like Northwestern, where they can really have a staff of professionals that are devoting their entire focus of their practice to this.
I think that's extremely well said. And, I know Elaine and the folks at Cleveland very well. I did my epilepsy training there, so.
Oh. And based on what I witnessed with my son being a patient there, I felt it was a very, very safe place for him to be. He'd be starting to have a seizure. And before I even would notice evidence of it, people were already coming into the room saying, Anthony, the color is green, the number is 2, here's how many fingers I'm holding, and boy, they were just so on top of it that I didn't feel like I needed to be there to watch and make sure what was going on. I mean, I just did because I'm his mom and I've kind of been through this with him, and I didn't want him to be alone there all the time. But to the lady who talked about someone else being worried about it, I just felt, I'm a registered nurse too, and I just felt like from a clinical angle, from the angle of being a family member, having a loved one going through this, boy, what a top-notch place. So I have no fear for anybody who is considering it. It's a very safe and sound place to be.
Thanks for that endorsement.
Yeah.
Thank you. I think that's a really positive note to end our talk on. I think this is a really eye-opening.
Actually, do you have one moment?
Oh.
I apologize. I came in here late. I just had the opportunity to spend time over at the EMU at Northwestern a couple of weeks ago. Went through the full battery, and I was wanting, at this point, knowing that it's going to be inevitable, that surgery it's going to be surgery. It's without a doubt. I think that's the route to go. After having the craniotomy 25 years ago, getting hit with
Oh, we lost you, John.
Oh, there.
Gotcha. I think you're back now.
Okay. So, yeah, 25 years ago, I had the surgery over at Northwestern campus that was removed. Slowly had, I believe from what you guys were saying, I guess there. But it was just recently over at the EMU. The last 25 years, I've definitely seen a decline right away with the children. Everything that kind of goes along with the hippocampus. Now, when you do the battery of tests, do the WADA test, you go through the neuropsych, all of that. If you opt for the surgery, are you going to then able to prevent additional cognitive deficits? Because if it surgery caused cognitive deficits once, then wouldn't surgery or some kind of innovation into the brain then possibly cause more problems?
So certainly having repeat surgery is never easy. But I think the question of whether repeat surgery will cause additional cognitive issues is dependent on exactly where we're operating and what we're doing. Meaning, depending on where we are, it can possibly have a risk of additional cognitive deficits, or it may not, depending on where we are.
Okay.
And that's an individual discussion to have as you go through the whole surgical process, John.
So is there a way to kind of pick that out, almost talking about it even as the team, looking at the neurocog, looking at it so variable because the brain is different?
Yep. And that's certainly, again, that's certainly a discussion as you discuss surgery with folks, to make sure that you bring that up and ask that question and have that discussion as part of the run up to surgery if you get that far. Absolutely. That's why we're here. And we're not, we always like to set expectations appropriately. We're not here to tell you something that's not realistic, right? It's the better information we can provide you with, the more realistic we all are about how surgery goes. And look, surgery is not perfect, right? Both in terms of seizure freedom rates and in terms of risks and stuff. Surgery is not perfect, but as you heard before, if medications can have only a 6% chance, additional medications of making someone seizure free, and if we tell you that surgery has a 50% chance, now normally if someone said 50-50, that doesn't sound so great, but 50 compared to 6 is actually much better.
Well, thank you so much, Dr. Rosenow. We've definitely taken our hour of your time, so thank you for being here, for enlightening us, and for giving a lot of your expertise to everyone on the call. And it was just great to have this format instead of a PowerPoint, as you said in the very beginning. So I hope everyone enjoyed that.
Well, thanks everybody for signing on. This is super. Happy to do it again anytime.
This was wonderful. Thank you so very much to everyone who put this together, and to you, Doctor.
This is all put together by everybody at the foundation. They're always here to make sure that everyone around this area gets the absolute best care they can get. All right, everybody, have a wonderful night. Stay safe.
Have a good night. Thank you.